ultrasound of the pelvic floor. What lies beneath? I will start my lecture with pelvic floor anatomy. Pelvic floor muscles are divided to superficial and deep. On this side, you see the superficial muscles, where we can find the musculus bulbospongiosus, musculus ischiocavernosus, and superficial transverse perineal muscle. On the other side, we find the deep pelvic floor muscles, where we find the external urethral sphincter, deep transverse perineal muscle, and levator-ani muscles. Here we can see pubococcygeus and iliococcygeus muscles. There are three levator-ani muscles, the puborectalis muscle, which we can see here, the pubococcygeus muscle, and both they attach to the inferior ramus pubis. And then we see the iliococcygeus muscle, which attaches to the arcus tendineum of levator-ani muscles. And the pubococcygeus muscle, this one, consists of three parts: the puboanal muscle, puboperineal muscle, and pubovaginal muscle. Here I will show you some images on the muscles I mentioned before. Here we can see the bulbospongiosus muscle, which is in blue. We can see the ischiocavernosus muscle, the perineal membrane, and here we find the iliococcygeus muscle and the pubococcygeus muscle. Here you see the puborectal muscle and puborectal muscle attaches to the ramus inferior pubis, and it cones and surrounds the anal canal, where we see on this side image that the puborectal muscle goes down and he holds the anal canal here. Perineal body, which you see here, is a very important part of the pelvic floor, and it supports the pelvic floor structures. Perineal body consists of bulbospongiosus muscle, levator-ani muscle fibers, external sphincter, and we have the superficial transverse perineal muscle. Anal canal, there are three levels of anal canal: low level, middle level, and high level, and each of these corresponds to the three parts of the external anal sphincter: the subcutaneous part, the superficial part, and the deep part. And here we can see the internal anal sphincter, which starts just below the subcutaneous part of the external sphincter, and then continues and goes over to the rectum muscles. During vaginal birth, pelvic floor trauma may occur, and it can occur the perineal tears of different grade. Superficial and deep pelvic floor muscle may be damaged, and also it can occur damages in fascias, in nerves, and ligaments. During second stage of labor, during vaginal delivery, levator-ani muscles stretch 2 to 3 times of their length. And here we can see in the experimental study that the pubococcygeus muscle is the one that stretches out most. And when the levator-ani muscles need to stretch 2 to 3 times their original length, there is high risk of the damage. And what happens? They may detach from the insertion site to the ramus inferior pubis. And here we can see that the puborectal and pubococcygeus muscles are attached, so we see no avulsion. And on this image we can see the defect or the detachment of the pubococcygeus and puborectal muscle. Besides the damage of the levator-ani muscles, we can also observe the sphincter ruptures during vaginal delivery. If we want to assess pelvic floor anatomy, and if we want to detect the possible damage to the tissues, we have to use ultrasound. We may choose the static or dynamic, 2-dimensional, 3-dimensional, and or four-dimensional ultrasound, and we may use the transperineal or transvaginal approach. And of course, we can combine those different ultrasound modalities. When we do the transperineal scan, we use the obstetrical probe. We use the transabdominal probe, which we usually use in obstetrics. And here I show you three-dimensional probe. If you want just to do the assessment during contraction of Valsalva, it's enough that you use the 2D probe. And we attach the probe in the sagittal position to the perineum in order to achieve the mid-sagittal section. And here in this ultrasound image, we see the mid-sagittal section of pelvic floor. And it corresponds to this schematic image over here. So here we see we have the symphysis pubis. Here we have the urethra, the hypoechoic structure here. We have the urinary bladder. Here we have the vagina, which is here. Then we go to rectum. We see the rectum. And then we see the puborectal muscle, which is a part of levator ani muscles. And the probe is attached to the perineum here. What can we assess in this image? We can assess the distance between the symphysis pubis and the puborectal muscle, which is the minimum hiatal dimension, if we are correctly in the sagittal view. We can also use the dynamic assessment. We can ask women to contract, and when she contracts the pelvic floor, the symphysis pubis and the puborectal muscle, they come closer to each other, and it means that the hiatus becomes smaller. I will show you again. And in this case, we can give the biofeedback during pelvic floor exercising to the woman, for example. And we can also assess the strength and the duration of the contraction. We can also assess pelvic floor during Valsalva when we ask women to push. And in that case, we can assess the anterior or posterior compartment with regard to cystocele, rectocele, or enterocele. And here again, it's very important that we have the mid-sagittal view. And then we ask women to push. And when she pushes, we look at the urinary bladder, we look at the rectum, and we look at the lowest part of the symphysis here. I see lowest because the transducer is close to the perineum, and this is the lowest part of the symphysis pubis. We draw the reference line, and ask women to push again. And we see that neither urinary bladder or rectum goes below that level. So that means that there is no cystocele, no rectocele, no enterocele in this case. And here we have another case where we ask women to contract and then push, and now she will push. And then we see that the urinary bladder goes and almost reaches the symphysis level. And look also at the posterior compartment, don't forget that, we look at it. And we see that the rectum here, rectum wall, we ask her to push, and then it goes, reaches and goes below the level of the symphysis pubis. So it means that woman has rectocele. If we want to further assess the deep pelvic floor muscles, we need the 3D and 4D ultrasound. As we know, the pelvic floor is a 3D structure. So in that case, we use the 3D ultrasound probe. We find the mid-sagittal section. We use the maximum angle of the acquisition. It should be at least 70 degrees. And then we use the high quality acquisition, which means the low speed acquisition. We find the mid-sagittal view, which you are now familiar with. And after the activating 3D box, we get the multiplanar view, where we have the pelvic floor in the sagittal view, transverse, and the coronal view. Then we can activate the rendering mode, and here we can choose different types of rendering. The green line is the reference line. It is very important that we adjust these settings, and for rendering, it is recommended to use the 80% transparency and 20% surface rendering. And then we see the coronal view, rendered coronal view, where we can see the urethra here, the vagina, and the anus, and here we can see the puborectal muscle around, and this is there we see the ramus pubis inferior here. Here I will show you a couple of patients that have been examined with the new equipment, Wallace and Swift, and you see that image quality is very similar. And if we look here in the rendering mode, we can see the urethra again, the vagina, the anus, and we see the attached. There is no detachment of the puborectal muscle, and we see this is the ramus inferior of pubis. And here is another patient where we see again the urethra, vagina, anus, and the puborectal muscle and the ramus. And here again, we don't see any detachment. Here I will show you how different rendering modes can be used in order to assess pelvic floor. We see here the urethra, vagina, anus, and ramus here, and you see the same structures on other images. And here I will show you even more how you can manipulate with the ultrasound equipment and with the new equipment as well, and get and use different rendering modes. Pelvic floor can be assessed also using OmniView VCI, and here you see the assessment during contraction. You are already familiar with this coronal view, and you see that the puborectal muscle is attached to the ramus inferior of pubis, and this woman contracts, the muscle becomes thicker. And here is another case where we ask women to contract, and we see that on the left side there is no detachment, and then on the right side it's something happening, and we see here that there is an avulsion of the levator muscle. During Valsalva, maximum Valsalva, we can measure a hiatal area. In that case, we activate OmniView VCI and ask women to push. And at maximum Valsalva, we measure the area. And if this hiatal area is of 25 or more square centimeters, here is the levator avulsion. In order to assess levator muscle integrity, it is recommended to use tomographic ultrasound imaging and do the assessment during contraction. And then again, we have the mid-sagittal view, the transverse view, and the coronal view. And when we activate tomographic ultrasound imaging, we get the 9 images that corresponds to different levels of the pelvic floor. And these 3 images are of interest to us. We see the same structures as before, urethra, vagina, and anus, and puborectal muscles. And what we look at the gap, at the urethral gap, levator-urethral gap, which is from the middle of the urethra to the attachment of the levator muscle. And we measure that distance, and if that distance is below 25 millimeters, it is normal. And if this distance is of 25 millimeters or more than at least 3 central slices, these 3 central slices, it shows the full levator avulsion, which is of clinical importance. And here I show you another case where we can see on the left side we have no problem, no detachment, but on the right side the muscle attaches here. It means that there is a gap, and when we measure it, we get it above 25 millimeters. And as these 3 images are involved, we consider it being full levator muscle avulsion. Here I will show you a patient that has been scanned with the new equipment, Wallace and Swift. And you see that, again, image quality is pretty similar to the previous one. We can see the urethra, vagina, anus, and the puborectal muscle is attached to its side. There is no detachment. And here is another case where we see that there is no detachment here, and if we measure the distance, we get below 25 millimeters. When assessing anal sphincters, it is very important to keep in mind that we have to assess both sphincters, internal and external, and we have to assess all three levels of the external sphincter. When we do the assessment by using transabdominal probe, we apply probe in transverse section and tilt it to the sphincter. If we use the transvaginal probe, we have to keep it just inside or at the level of the introitus and tilt it up in order to cover the sphincter area. And here we can use both two-dimensional or three-dimensional approach. Here you can see the transabdominal two-dimensional approach, where this hyperechoic or echogenic ring around is the external sphincter, and the black one or hypoechoic thing is the internal sphincter. And here we see the mucosa, rectal mucosa. And here we see the transvaginal approach with the hyperechoic external sphincter, hypoechoic internal sphincter, and mucosa. And we don't see any defects or disintegrity in these structures. And here I will show you 3 patients that has been scanned using Wallace and Swift, the new equipment, and we see again the anal mucosa here in the middle, the black hypoechoic ring, which is the internal sphincter, and the white, which is the external sphincter. And here we see that the internal sphincter disappears at this level, which is a sign of the defect. As I mentioned before, it is very important that we assess all 3 levels of the sphincters, and we start at the low anal canal level, where the subcutaneous part of the external sphincter is situated, and on that level we don't see the typical image. We don't see the internal sphincter, we see only external sphincter. When we start seeing internal sphincter, now we see the 2 rings, the hyperechoic, we are at the middle anal canal level, and where is the superficial part of the external sphincter. And then if we go above, we see that we start seeing the puborectal muscle around. You remember, I showed you anatomy picture, that puborectal muscle is surrounding the anal canal, and in that level we are in high anal canal level, whereas the deep part of external sphincter. It's very important to keep in mind that the external sphincter disappears here between 11 o'clock and 1 o'clock. And this is because of the anatomy. This is not a defect, but this is because of the anatomy. Then we can use the 3-dimensional ultrasound and take the volume during contraction, maximum contraction. And we can do it by using the transabdominal or transvaginal approach. And in that case, we save again 3 images and activate tomographic ultrasound imaging, where we create 9 slides. And here it's very important that we cover the whole anal canal with our slices, and then we have to look for defects in each slice, which means that we look at the internal external sphincter in each slice and we see if there is some defect. And if we find defect in at least 4 slices, any slices, then this defect is clinically relevant if it's above 30 degrees. And here another different rendering mode where we can also assess the both sphincters, and then again we don't see any defects. Here is a patient scan with Wallace and Swift, and another patient, and here we don't see any defects. If we want to look closer to the sphincters, we can use a high definition rendering mode where we see here anal mucosa, internal sphincter and external sphincter, and the same here. If we find any defect, we have to measure it. and we measure it in angle, and we measure it in all slices when we find the defect. So we see here internal sphincter is without defect and external sphincter is damaged here. So we take the angle function in the measurement and we point to the middle of the anal canal and go back for the margin of the defect. And then we measure it as an angle, and we do it in all the slices, and we have at least 4 slices, and the defect is at least 30 degrees. So this defect is clinically relevant and important. So in this lecture, I have showed you that pelvic floor can be assessed using static and dynamic, 2-dimensional, 3-dimensional, and 4-dimensional ultrasound, and of course, different modalities may be combined. I want to thank you all for being with me and listening, and I hope you will enjoy using ultrasound and scanning pelvic floor in your practice. Thank you very much.